It is really my truest, distinctest honor to have Lucas Hill presenting for us today. I think we all have so many wonderful things to say about Lucas, and as we've gotten to know him better over the years, it really is a privilege to work with him, and does so many incredible things for the Owen Clinic on so many fronts, but I'll just tell you about him. So he's the lead clinical pharmacist, or he leads the clinical pharmacy team at the Owen Clinic and is an assistant clinical professor at Skaggs School of Pharmacy. He completed his PharmD at the University of Southern California and then residency at UC San Diego in 2012, coming to UCSD specifically to work and train with Craig Ballard at the Owen Clinic. After residency, he joined the clinical pharmacy services for the hepatitis C monoinfection clinics at UCSD and also assisted with the HIV hepatitis C co-infection clinic until 2017 when he fully joined the pharmacy team at Owen Clinic. And we have an interesting fact that I asked Lucas to provide. I love this. So he took a year off before pharmacy school and worked at an antibody production facility in rural Pennsylvania. The job was located on a farm where they raised animals to generate the antibodies. And this is where he met his wife. She was leaving the job and had to train Lucas on antibody conjugation. And so he spent more time flirting than learning to conjugate antibodies. Unfortunately, that's not what he has to do here with us. So anyway, I will turn it over to you, Lucas, and I'll keep an eye on the chat for you and interrupt only where appropriate.
Okay, thanks, Jill. Hi, everybody. I hope everyone had a good day off yesterday for Veterans Day. And hey, we're working on our 14th year, so at least I did something right. And probably better that I focused on her than antibody conjugation. But today I'm going to talk about the Owen Clinic experience that we've had so far with long-acting cabotegravir rilpivirine. So as most of you know, cabotegravir was approved in February. So we've had now coming up on, close to a year now of experience with working through some of the logistics around getting people on long-acting cabotegravir. So today I'm going to really not talk much about, the studies or the efficacy data, because I think that stuff's been presented before. So today we're going to focus mostly on what some of the logistical challenges have been and some of the strategies we've used to overcome some of those challenges. And I'm hoping to hear from others on the call, because I'm sure there's been other experiences and they may change or vary depending on your practice site. So we'll get started. Disclosures. So this is the one slide I just wanted to include to remind you about the Atlas and Flare studies, which were the large phase 3 trials that led to the approval of long-acting cabotegravir. And so Atlas was a study where patients were on stable oral ART and were switched to long-acting cabotegravir. And then Flare was treatment-naive patients who were initiated on oral therapy with ABC3TC dolutegravir, and then ultimately randomized 1-to-1 to either continue that or switch to the injectable therapy. And so the graph on the left is the outcomes at week 48 in terms of viral suppression that compared cabotegravir long-acting in the green versus continuing oral ART in the purple. And obviously you can see that they were equivalent in terms of virologic success rates, so close to 94% for both arms. And then the graph on the right shows treatment differences based on different populations in the studies. And as you can see, there were no significant treatment differences between any specific patient population. And then as a reminder, this is the package insert indication and dosing recommendations for long-acting cabotegravir. So it's indicated as a complete regimen for the treatment of HIV infection in adults to replace current antiretroviral regimen in those who are virologically suppressed, and they define that as a viral load of less than 50 on a stable antiretroviral regimen with no history of treatment failure and no known or suspected resistance to either cabotegravir or rilpivirine. And so, as you know, prior to initiating treatment with the injections, there's an oral lead-in that's recommended that should be used for approximately 1 month to help assess tolerability to the medications. And we'll kind of talk about some of the issues maybe around the oral lead-in. And then the dosing of the injectable is to initiate the injections at a loading dose of 600 milligrams of CAB and 900 milligrams of rilpivirine on the last day of the oral lead-in, and then continue with a monthly maintenance dose of 400 milligrams of CAB and 600 milligrams of rilpivirine every month thereafter. So like I said, I think most of the focus today will be on some of the logistics and challenges around scaling this up in clinical practice. So we'll hit on some issues around how to select patients and patient selection process, drug-drug interactions that might come up during the oral lead-in, particularly with rilpivirine. Probably one of the biggest ones that I'll try and touch on a little bit is reimbursement, acquisition, and billing for the medication. How potentially you can use the EMR to help, and also how we track injections, the need for resources to administer the injections, the need for resources to do patient outreach, especially around missed doses and no-shows, strategy for viral load monitoring for patients that are switched, the idea of using an oral bridge for those that miss their monthly injection, and then what to do for patients who are hospitalized while on long-acting rilpivirine. So I have a poll question, and I think Marvin's going to pull this up. So the poll question is, how many patients have you or your practice initiated on long-acting rilpivirine? So 0 patients, 1 to 10, 10 to 25, 25 to 50, or greater than 50.
Lucas, we're at about 46%.
Okay, maybe just another few seconds and then we can close the poll.
Okay. All right, just over 50.
Okay, that sounds good.
Okay, I'm gonna share it now.
Okay, so yeah, so this is about what I expected. So obviously the majority have not yet initiated anyone on rilpivirine, but there is 35% participants that have started from 1 to 10. And then some of the higher numbers at much lower percentages. And so, you know, I think partially this speaks to maybe some of the difficulties with getting this scaled up in real world practice. At Owen Clinic, now this is, you know, for our entire practice, obviously not per individual provider, but I think at this point we're at 56 or 57 patients that have initiated rilpivirine. So let's go to the next question. Oops, sorry, Marvin. There we go. So the next poll question is, if you have attempted to start patients on this, what have been the biggest barriers to rolling out or initiating long-acting rilpivirine? Has it been identifying appropriate candidates, reimbursement or acquisition, challenges within the EMR, not having resources to administer injections, not having resources for patient outreach, or missed doses, or other?
Lucas, can you hear me? Oh,
Sorry?
I said, Lucas, can you hear me? And that answered my question. That I've got some major volume problems right now. I'm working with 2 devices. So anyway, but yeah, sorry. I was just going to brag about the fact that there are almost 85 people attending this. This is a very highly attended
Oh, good.
talk.
I'm glad to hear that. I hope it's useful.
Yeah, sorry.
Um,
Testing out my volumes.
yeah.
Yeah, more like 30 people.
So the answers, a little bit of a split between identifying appropriate candidates, and then also, not surprising, is the reimbursement acquisition piece, and then a smattering of other issues, including resources, which I think is definitely important to recognize.
And Lucas, the comment from a couple of people, what was that you needed an all of the above option?
Yeah, right. Good point. Yes, that's a good point. Yes, I think there are obviously many challenges, and they're not isolated to single issues. So before I kind of get into what we've kind of been doing or seeing at our clinic, I just wanted to give a few background, a little bit of background information about some of the issues I mentioned. So one thing I wanted to touch on briefly was the customized study. And this was a study done that was focused on implementation. And it was done to kind of help identify both patient and provider perspectives about what some challenges might be for implementation. So one of the questions they asked, I had 105 patient participants, and they asked what your concern is with oral ART. And the number one identified issue was having to hide their medications from others. So 47% said they had no problems taking their daily medication, which means over half obviously did. And having to hide their medications came out as the first challenge. And I think we see that in clinical practice a lot for patients who have to hide their disclosure from people they live, their status from people they live with, and having to hide their medications. Next was problems remembering to take daily medication. So the challenge of a single pill once a day is still very real. Concerns about running out of medication, which is interesting because basically saying that, you know, the onus of refilling your medication on time when you're on oral ART mostly falls on the patient. And I think we see that, you know, those periods between when refills are due are often frequent times that patients run out of their medications, followed by out-of-pocket costs, worrying the pharmacy might not have the medication in stock, and then other. And they noted that cisgender men were more likely than women to report no concerns with daily oral therapy, and cisgender women were more likely than men to report concerns with remembering to take daily medication. I think we could all think about why what some reasons are for that difference, but they did also touch on perceived barriers by healthcare staff for implementation. And they looked at these perceived barriers at baseline, which is green, 4 months into the process of rolling this out, purple, and then 12 months in the blue. And most of the perceived barriers did decrease over the period of time of 12 months. Initially, the highest perceived barriers were that patients weren't going to be able to keep their monthly appointments, transportation to get to the appointments, which is definitely a valid concern, and then how do you flag or make patients aware that they missed their visit and get them back in. There's other things on here like resources, scheduling, things like that. So again, as healthcare staff got more experience with this over time, the perceived barriers tended to decrease. The one that stayed pretty consistent over the 12-month period was the issue of patient injection soreness. And about half of healthcare staff identified that as a potential barrier. For patients, so this is looking at what patients perceived as barriers, and I think the patient perceptions are in green, and the healthcare staff perceptions are in purple. So I think the first thing that stands out is that there were fewer issues in terms of patient perception about implementation as compared to healthcare staff, who seemed to be more concerned about some of these barriers. But for patients, the number one thing that stood out was injection pain soreness. And then it was followed by low numbers for transportation, rescheduling missed visits, and scheduling injection visits. So in the customized study, they did identify some best practices and some successful infrastructure changes that helped improve implementation. So some of the infrastructure changes were extending clinic hours, having increased coordination with other departments within the healthcare system, probably related to scheduling and coordinating appointments and things like that. Purchasing new refrigerators. So yeah, I have to say for Owen, we did have to purchase a new refrigerator when we were getting ready for cabrolpivirine. And then available room space, which is going to be practice specific in terms of how much space you might have. Some summary of best practices: calling patients 2 days after the first injection for a check-in. I think this is a nice idea. We haven't been doing this with our patients, but it is nice to maybe give them a call a couple days after they initiate the injection, just to give some reassurance and see how they're doing. Adding a physician to the morning huddles. This was an intervention at the AAHIVP clinic that they included in the study, and I think this is mostly around staff communication. That's important. Using telehealth to send patients product information, which is a nice idea to leverage the EMR and use things like MyChart and other electronic communication methods to send patients information. Scheduling visits as far out as clinic schedules allowed, and booking more than 1 month in advance to prevent overbooking. So this, I think we're starting to do this with our patients. Instead of scheduling a visit every single month that they come in, is we're scheduling multiple monthly visits. And it probably helps with multiple things. One is the patient being able to see kind of into the future about each injection visit, help them plan, and then obviously also if they have other healthcare issues and the need to attend other appointments, it helps them manage their schedule and prevent overbooking. Also for the clinic, because you've now got a visit scheduled out ahead of time, so you're not overbooking certain days. EMR templates for injection visits. I'll show you a little bit what we've done in Epic and to help with this injection process, and then before and after walk-in hours for injections, which I think is really nice. But that is a challenge, I know, for us at Owen. It's something that I think many of us would like to do, but there's a lot of logistics around making that available for patients. But as you scale this up to a larger number of patients, after hours appointments would be very helpful. Okay, so next polling question is, which type of patient do you think is a good candidate for long-acting cabrolpivirine? And I don't know if you can choose multiple answers, but history of consistent viral suppression with no adherence concerns, difficulty adhering to daily oral ART for various reasons, but adherent to clinic appointments and follow-up, and patients who might have ongoing barriers such as substance use, psychiatric disease, and homelessness that make it difficult to adhere to oral ART. So this question gets at some of the patient selection issues. I think, Marvin, for the sake of time, we can close the poll.
Okay.
Okay, so interesting. So 60% identified the first group, which I think is kind of the group that may be the easiest and the ones that will more easily roll into this option are those with good suppression and no adherence concerns. But a lot of people are identifying those that may struggle with oral adherence to oral therapy, but do come to their clinic appointments. And then the concern about those that have trouble, other barriers that might make it harder for them to come to the clinic, are the ones that are going to maybe really see potential benefit from this, but have some of these logistical challenges. And the next question is related to resistance testing. So when would you consider getting an archived genotype prior to initiating injectable cabotegravir/rilpivirine? A history of multiple ART regimens with unknown response and no prior genotypes available. Baseline genotype, you have a baseline genotype and they have had consistent suppression ever since starting ART. You have no baseline genotype, but they've always been suppressed on an inhibitor-based regimen. You have no baseline genotype and a history of NNRTI-based regimens and always suppressed. they're currently undetectable on ODEPSI with no available resistance tests, or everybody. Okay, Marvin, if you want to close the poll.
Okay.
All right, so yeah, interesting. So most people would say they would get one in patients who have multiple ART regimens and no prior genotypes and unknown response. The least selected option was if you have a baseline genotype and consistent suppression, which I agree. I think that's the one, basically the one scenario where we're not getting archives. I can say, and I'll kind of show the information as to why, that we're generally doing archives in most of these other groups of patients. So just to touch on the issue of resistance around long-acting cabalpivirine, these are the 6 failures from Atlas and Flare with confirmed virologic failure. I think what stands out is, one, the majority of patients, or all of them actually, were subtype A. So that definitely stood out in this study. And then 2 of them had baseline E138 mutations in RT. And then when they failed, after failure, all of them had rilpivirine resistance, and 4 out of the 6 had integrase resistance. So one thing this shows is when patients do fail this regimen, it's very likely they develop resistance to the components. And then this is the Atlas 2M failures. Atlas 2M was a study that compared Q4 week versus Q8 week cabalpivirine. And there were 8 failures in the every 8-week arm and 2 in the every 4-week arm. And what stands out again, now there were different 8 subtypes in the virologic failures, so A1 wasn't exclusive to that. But there were 1, 2, 3, 4, 5 out of the 10 who had baseline NNRTI resistance. 1 had baseline integrase resistance. And then again, the majority after failure developed both NNRTI and integrase resistance. And so they did explore what were potential predictors of failure. As a reminder, about 1% of patients of 17 had confirmed virologic failure among the Flare, Atlas, and Atlas 2M studies. And they looked at a multivariate analysis that evaluated CAB and rilpivirine trough concentrations at week 8, as well as pre-existing resistance mutations, and then adjusted for sex assigned at birth, BMI, HIV subtype, and comparing Q4 versus Q8 weeks. And so what came out is predictive of failure. The strongest predictor was having baseline rilpivirine resistance. Other things that were predictive was lower rilpivirine concentrations at week 8, a baseline subtype A, A6 or A1, and a higher BMI at baseline. Things that did not predict failure were pre-specified INSTI resistance, lower CAB concentrations at week 8, being female at birth, every 8 versus every 4 weeks once you controlled for these other factors. The L74I polymorphism we didn't touch on. That seemed to potentially be something that might predict failure, especially in the Atlas and Flare studies, but when you control for these other factors, it did not. And then other NNRTI RAMs than rilpivirine resistance also was not significant. And what they identified as having 2 of these factors had the highest sensitivity and specificity for predicting failure. And so evaluating for baseline rilpivirine resistance is essential. And I'll talk a little bit about the idea behind that. But I also wanted to touch on this study that was very recently published that was done in a French cohort looking at in treatment naive people who may not be eligible for cabalpivirine based on resistance. And so they looked at over 4,000 treatment naive patients between 2010 and 2020 and looked for baseline resistance to rilpivirine, cabotegravir, or both. There were many that were not subtype B. And they found 16% had at least 1 cabotegravir resistance mutation, but if you exclude the L74I, it was only 3%, and 14% had at least 1 rilpivirine mutation. So using the resistance algorithm, they predicted that 0.74% would have been resistant to cabotegravir, 6.2% to rilpivirine, and 0.09% to both. and the overall presence of the E138A was 3.2%. So this mutation affects rilpivirine, and it can be polymorphic. So it could be present without any NNRTI exposure, and in someone who's been suppressed on whatever regimen. And so you have to consider the fact that you probably should look for this mutation or this polymorphism before initiating cabrilpivirine. So when they put together their subtype A sequences, as well as 244 sequences, they determined resistant to rilpivirine. They estimated that 10% of their patients would not be eligible for cabrilpivirine based on resistance. Moving on to the oral lead-in, some logistic challenges. One is that it's mail order only, so it's restricted to a single pharmacy called Theracom. So, this obviously presents challenges for patients who either don't have mailing addresses or unstable situations where they're not comfortable with medication being mailed to them. So it requires coordination to maybe have it mailed to the clinic. The issue of drug-drug interactions with rilpivirine and acid reducers for the oral lead-in. So as you know, many of our patients are on PPIs, and how do you manage doing an oral lead-in with rilpivirine? So for us, we've been asking patients to stop their PPIs, and so far everyone except one has been able to for the 4-week oral lead-in. The other one that didn't, we actually shortened the lead-in. The need for it to take with a meal, so that requires maybe an adjustment to their schedule of how they take their ART. And then, we're talking about potentially using this injectable therapy in patients with adherence concerns. And so the issue of needing to be adherent for a month on what might be a lower barrier to resistance regimen than what they were previously taking also is an issue. And so the question is, do you need the oral lead-in? And so for us, we've been doing it for our patients, but the evidence is there based on this study that you may not need to do the oral lead-in. And this was a study that looked either direct to injection in the dark green versus using the oral lead-in in the light green. And the suppression rates at 48 weeks were the same, just whether they used the oral lead-in or not. And there were no safety concerns either with skipping the oral lead-in. So potentially that is a strategy to avoid some of those issues I mentioned. And this just shows that it's not a pharmacokinetic issue that you need the oral lead-in. So this shows the concentrations of cab and rilpivirine 1 and 4 weeks post-dose, whether they used or did not use the oral lead-in, and there was no difference. Finally, on missed injections, so just as a reminder, injections can be given plus or minus 7 days from the due date per the package insert. And so if an injection is missed by more than 7 days, then the patient should resume oral therapy for up to and they can do that for up to 2 consecutive monthly injection visits. And then if it's less than 2 months since their last injection, you can just resume with giving them their maintenance dose. And if it's greater than 2 months, then you're supposed to resume with the loading dose. And I think a lot of questions are around what impact does missed injections have on efficacy? And I think the answer is we don't really know because there were such good adherence to injection visits in the Atlas and Flare studies. So this shows that 98% of injection visits were within the 7-day window. They had 46 early injection visits and 106 late visits. 96 injections of the late ones were given 8 to 14 days late, 10 were given 15 to 28 days late, and there were 7 patients who utilized the oral bridge. All of those 7 maintained suppression, and there were no participants who had virologic failure at week 48 that had a missed or late injection. So, I mean, I think it's reassuring, but again, I think this is a pretty optimal setting and may not completely mirror what might happen in the real world. So I'm going to move on to Owen Clinic, but I think we wanted to pause just for a second to do a quick poll, right, Jill?
Yeah, thanks, Lucas. And just really quickly, while we're bringing up the poll, there was a comment about the archive and how much you trust it. And I'm actually surprised to see that question. And I was wondering if you could respond to that.
Yeah, I think it's an important question. How much we trust the archive. I always interpret them cautiously. I think it's another tool, and if it shows up on the archive, then you have to consider it, of course. If it doesn't mean that something's not there. So there's always that correlation with getting a good history, ART history, to kind of match what you see on the archive with what you might expect from their history. So I think of it as a tool, but it's not perfect.
Okay, and I don't want to close my poll. Oh, so bad at this. Well, I guess we can, I don't know if anyone, sorry, I should have said what we were trying to do, which is we're trying to get a sense of high rounds for next year. And I think people can read what the question said, that if high rounds was moved to a hybrid meeting, how would you prefer to attend? The idea is that we would still offer both options. We're just trying to get a sense if there is a desire to come back in person, and this is almost exactly what I expected to see. So thanks for confirming my biases. Marvin, do you think that's we're good? So we have a sense?
Sure, we can move on. Yeah, thanks.
Yeah, thanks so much, everyone.
All right, thanks.
And if you have any comments, you can message me or Marvin separately if you have anything else you want to share. All right, back to you, Lucas.
Okay, thanks. All right, so I'm going to spend the rest of the time. The rest of the time talking about our process here at Owen and what we've seen, and hopefully there'll be some time at the end for discussion. So this is our process for getting people on cabrolpivirine. So you have a patient who expresses interest. The eligibility is reviewed by both the provider and also our clinical pharmacy team, and the decision on what resistance workup needs to be done. So for us, we're not doing archives if they have a baseline genotype. So we were able to look for polymorphisms, and we know they've been suppressed since. But in general, otherwise, if we don't have a previous resistance test, we are getting archives in almost all of those situations. After it's determined the patient's eligible, insurance coverage investigations done. And this includes researching what the patient's responsibility would be and how to address those. And this is a joint effort between our outpatient pharmacy, our pharmacy technician at Owen, Allen, and the rest of the pharmacy team. After that's all sorted out, the patient's contacted to review the oral lead-in, and the delivery of the oral lead-in is set up to the patient's home or to the clinic per their preference. The patient's instructed to contact the clinic when they receive the oral lead-in to schedule their first injection visit. And then at that time, a treatment plan is entered into Epic, and I'll show you what that looks like. We then fortunately have gained access to cabrolpivirine through our UCSD pharmacies. And so the medication is obtained from an outpatient pharmacy or purchased by the clinic if it's a buy and bill situation 1 week prior to their injection visit. And we use a tracking sheet in Excel because I haven't figured out a way to leverage Epic yet to do that, to know when to get the medication. We do a reminder call to the patients the day before each injection. Our pharmacy students and residents do that. The first injection visit we schedule as a nurse visit, but also with our clinical pharmacy team. And we've created a patient counseling sheet that we review and have the patient sign and scan into Epic. So we have documentation that all of that stuff has been reviewed. For us, our viral load monitoring is done. We do a viral load at the loading dose. So after they completed the oral lead-in, we do another viral load at their first maintenance dose injection. And then if everything looks good, generally every 3 months. And then subsequent visits are scheduled as a nurse visit, and we maintain a tracking sheet for all patients on cabrolpivirine. So when we started doing this, we kind of talked about as a clinic, what our idea for patient selection would be, and what we are looking for good candidates for this. One is consistent viral suppression on their oral therapy, and we decided for a minimum of 2 to 3 months. Related to hepatitis B infection, confirming that they are surface antigen negative, and if they are isolated core positive, doing a one-time Hep B PCR to rule out occult hepatitis B. And then, of course, if they are core positive, considering the risk of not having a patient on Hep B prophylaxis or treatment, however you want to refer to it. And then, of course, offering vaccination if indicated. We're looking for consistent adherence to clinic appointments and a willingness to come every month, of course. I think a big one is having a way to reach the patient. So either a working phone or access to my chart, because if you can't reach them and they miss their injection, it makes it really difficult. Obviously, no history of documented or suspected virologic failure to rilpivirine or integrase-based regimens. The ability to take oral rilpivirine for a month, being the food requirement, plus what I talked about with PPIs. Not being on potent CYP3A4 inducers, as these can affect drug concentrations of cavalpivirine. And then, as I had mentioned, if there's no baseline genotype or archive, we consider getting an archive to evaluate for NNRTI mutations. And then lastly, discussion about risks and need for contraception in people of childbearing potential, as this hasn't really been studied in that group.
Lucas, there were just a couple of questions. I'm sorry.
Yeah.
So Tyler asked how long the initial process takes and how does it compare to starting oral ART?
Yeah, good question. Longer than oral ART. How long is somewhat dictated by the patient's insurance. If it's a plan that needs a prior authorization, that's going to take at least usually for us a week or two to sort out, because then you have to also figure out patient responsibility. And then if they need a resistance test, obviously that's going to delay things as well. So it's hard to put a number on it, but it's definitely longer than just putting someone on oral ART.
And then Nettie, there's going to be so much coming up. But can you explain the buy and bill pharmacy system?
Yes, so we're going to do that now. Is
Okay,
it okay if I go forward? Yeah.
Yes.
Okay. So this is just a little bit about reimbursement. So when you think about paying for this drug, it really can come out of one of two pools of money. It's either a pharmacy benefit or a medical benefit. So insurers that pay for it as a pharmacy benefit tend to be Medi-Cal, ADAP, and Medicare. And in this case, it would be filled at an outpatient pharmacy as any other medication, and then supplied to the clinic and administered as a patient-supplied medication. So the clinic is not billing for the drug when they administer it, because it's paid for at the pharmacy. Of course, there's the issue that this is a limited distribution drug, meaning only certain pharmacies have access to it. You can request access from ViiV, and for us, the game changer is getting access at our pharmacies. There's zero chance we could manage this by having to do all mail order from CVS or Credo or whatever it is. And another issue for us at UCSD is we don't allow medications administered in the clinic to be white bagged, which means sent from an outside pharmacy. So this would not allow access to our patients if we couldn't access it at our pharmacies. And then if there is copay issues, this would be like any other medication copay at the pharmacy. And they have copay cards available for that at cabanuvacopayprogram.com. If it's covered as a medical benefit, which is the situation for most commercial payers, then it's what's considered buy and bill, which means the clinic has to purchase the drug and then administer it and then bill the insurance for both the drug and the administration. And essentially then, the system gets a reimbursement based on the insurance coverage. And then at some point there will be a patient responsibility for a portion of that cost. So for us, when we have buy and bill, we purchase the drug from our hospital pharmacy. That gets charged back to the Owen Clinic, and then the Owen Clinic, after administration, bills the insurance for the drug. The main issue is that there's almost always a 10 to 20% patient responsibility for medical benefit, and then taking into consideration if they have high deductibles, and then what their out-of-pocket maximum is, because once they hit that, then generally there is no cost. And it's less clear how to cover the secondary costs to patients when it's a medical benefit. This is now on the ADAP formulary, and PAI OAHIP will cover the secondary costs if the bills are submitted to them. So if they have that secondary coverage, that's an option. I've been told that their copay program can actually be used also for medical billing. And I'm actually in the process of trying to figure out with our billing department how to make that work, because that would be an option for those that don't have that secondary OAHIP PAI. And then ViiV also apparently has a program that patients can submit their receipts for reimbursement, but we have not had too many go down that route. So I don't know if that answers Nettie's question about buy and bill.
Thanks, Ben.
Yes. Okay. So this is what our treatment plan is like in Epic. So for those that use Epic, this might be helpful. For those that don't, maybe not so much. But we decided to use Beacon. So Beacon is the system within Epic that is used mostly in the infusion center. And it actually works well when you're giving kind of in-clinic monthly injections because you can pre-build a treatment plan and then put in orders for, say, the next 6 months. And the orders can be released by the nurse whenever the patient comes in, and it doesn't need a specific order. So this is kind of what it looks like. You can see at the top, it says Caval, Cabenuva, and cycle 1. Day 1, cycle 1 would include, so some of these are defaults to Beacon. So provider communication, it just mentions that there should be an oral lead-in for at least 1 month to assess tolerability. There's pharmacy communication, that's just standard for Beacon treatment plans. It doesn't really apply to this. But then you also can have nursing communication, which says observe the patients for 10 minutes after the injection, notify the provider immediately if post-injection reaction occurs. And then the drug is in there. So cycle 1 defaults to the loading dose, and cycle 2 defaults then to the maintenance doses thereafter. So the provider signs these, and then the nurse will go in and click the release button every time the patient comes in. That drops the medication order into the MAR, which is where the drug is administered. And that's in the MAR is where it's indicated if it's patient supplied or clinic supplied. And that's how the billing then gets triggered on the back end. And then the nice thing about Beacon is that you can also say put lab orders in here. So you can say, if I want a viral load at cycle 1, cycle 2, whatever, you can pre-put in orders, and every time the nurse goes in and releases the cycle, it releases the orders to be drawn at the lab. And what's nice about this is if you have any experience doing clinic administered medications, it's actually quite hard to track when they're administered. So by using Beacon, it drops into a nice flow sheet. So it's very easy. You can see what this looks like, where you have the loading dose in May, and then every subsequent maintenance dose shows up on the flow sheet. In terms of how we're handling hospitalizations and oral bridges, as I mentioned, access to the oral cavalpivirine is limited to Theracom and is not that readily accessible. Cab you can't just get at any pharmacy as an oral drug. So our strategy is to use the previous oral regimen as a bridge. We tell patients to keep a supply at home on hand just in case. And then the issue for hospitalizations is, for us, it is not approved for inpatient use, only outpatient use. And so we will use their oral medications if they're due for an injection when they're in the hospital, and then give them the injection outpatient. Other resources, so we've created these cards that we put on the boxes for the nurses to check off before they administer Cabenuva. So informing the clinical pharmacy team and making sure coverage is good, making sure their counseling form is on file, releasing the dose from Beacon, administration site. So we're giving rilpivirine on the right and Cab on the left, so that we know if there's a reaction, we know which drug. Scanning the box, monitoring for 10 minutes, and then scheduling return visits. And I think we just recently also added on here verified BMI. For those greater than 30, we're using 2-inch needles instead of 1.5 inches. And then at the bottom is a Cabenuva card that we give patients every month. The purpose of this is really if they get admitted at an outside hospital, they could potentially show this so that the hospital knows at least that they're on Cabenuva, and also has the Owen Clinic phone number that they can call so we can figure out what to do, basically. So I just have a few slides on what we've seen so far for our outcomes. At this point, we've evaluated, 220-ish patients or so for this. I did go through and kind of review the data for the first 176 patients so that we had a definitive decision to start or not start. And of those 176, 49 initiated cavalpivirine, so 28%. We had a baseline genotype in 82 patients, so 46.6%. And we did an archive in 60 patients, so 34%. And just keep in mind that this data is before cavalpivirine was added to the ADAP formulary. So it's now on ADAP, so that changes access. So we didn't have good answers for secondary coverage for commercial payers and no access for those with just ADAP when I looked at this. So this is just a brief look at some of the characteristics of the patients. There's more to be done with this, but when we look at breakdown of age, the median age was 42, 47.7% white, 15% Black, 37% Hispanic, mostly male, so 8.5% were female assigned at birth. We had one patient who identified as non-binary. In terms of what ARV regimens they were on at baseline, so 64% were on 2 NRTIs plus a second-gen INSTI, 11% on 2 NRTIs plus the first-gen INSTI, 6% on an NNRTI-based regimen, and only 3% on a PI-based regimen. We had 9% or 16 patients that had transitioned from a 2-drug regimen and 6% that were on a multi-class regimen at baseline. For primary insurance, 40% Medicaid, 40% commercial, and then about 10% Medi-Medi, 6% Ryan White ADAP. Looking at the hepatitis B status, 72% were negative for hepatitis B, 23% were core positive, surface antibody positive, 3% core positive, surface antibody negative, and there was one patient evaluated who was surface antigen positive. And then about 10% of our patients were on PPIs at baseline. So I did kind of do a quick look at comparing those that did start, 49, versus those that did not start, 127. The only factor associated with starting was insurance. This is because those that started were more heavily towards Medicaid, and those that did not start were more towards commercial and ADAP. And again, this was really related to not primary coverage, but secondary coverage. So these are the reasons for the 127 patients that didn't initiate. So the top reason was uncertain coverage of out-of-pocket costs, and this was related to the commercial and insured patients. Next was inconsistent clinic attendance or not being able to easily be reached, followed by just not covered by the insurance, which was 12%. 12% decided just not to go forward with the process after talking to them about it. 12% had previously identified cabrolpivirine resistance. And we had 8 patients, or 6%, where cabrolpivirine resistance was found on the archive genotype that wasn't previously known, which is interesting. And then 3 patients who was restricted to an outside pharmacy and not allowed to use UCSD's pharmacy, and therefore we weren't able to get access to the drug. So
was that a...
Go ahead.
So sorry, gosh, I keep getting confused. Was that how did you get that information? Did you ask people, or was there some sort of survey that got sent around
about why they didn't start CAB?
Mm-hmm. Yeah,
that we keep track of all of it. So as we evaluated patients, we documented why they didn't start, basically.
Okay.
Yeah.
Thanks.
In terms of resistance, I'm not going to go through the previously known resistance in detail. There were 15 patients. Of those 13, it was because of various NNRTI resistance mutations that they had. Two patients had baseline potentially CAB resistance. But for the archives that we did, we found 2 Y181Cs, 2 E138Gs, which were likely transmitted resistance. E138A in 2 patients. One patient had an A/K, a G190S in 1 patient, and then there was one final patient who had a T97A plus a K103. Neither of those would potentially affect cabrolpivirine efficacy necessarily, but the patient had a very long treatment history, and we were concerned about that being markers for other resistance. So of those that had an archived genotype, 13.3% had a mutation identified that may have resulted in lack of efficacy of cabrolpivirine. Just to summarize some other outcomes, we had 3 patients so far that have discontinued treatment. One of them did not like receiving IM injections, so stopped. We had two other hepatitis B reactivations. Both were core positive, surface antigen negative, surface antibody negative with high CD4 counts, and I'll show you the details of those in a second. One patient with significant weight gain, but she did decide to continue treatment. No one so far lost to follow-up, and no missed injections. We've had one patient currently out of the country who's on an oral bridge. And we had one hospitalization so far. The patient was hospitalized when they were due for the injection at Sharp, but was discharged 2 days after the injection was due and came right to clinic for their injection. And fortunately, we have a good relationship with some of the pharmacists over at Sharp. So they had called us when he was there, and we sorted it out with them what to do. So I mentioned the hepatitis B reactivations. The first patient, like I said, was core positive, surface antigen negative, surface antibody negative, CD4 count was 419. And he had been on Triamix since 2015. So you can see he had a previous not detected Hep B PCR in 2019. The oral lead-in was started on April 22nd, and he got a loading dose on May 21st. And then on May 27th, had a Hep B PCR that increased to 101. So he was quickly switched back to BF TAF a few days after that. And Hep B PCR repeat a few weeks later was not detected. Surface antigen never turned positive. And then the second patient also isolated core positive. CD4 count was 677 on Odefsey and Tivicay since 2018. The oral lead-in was started on September 9th, and he had a negative Hep B PCR on September 20th. And then he came in and received his loading dose on October 7th, and the Hep B viral load was less than 10. So we weren't really sure what to make of that, if that was really real or not. And so then we rechecked it when he came in for the maintenance dose, and it was 95. And so he was quickly then transitioned to BF TAF. So, I tried to search the literature for surface antigen negative, immunocompetent patients who are core positive and have reactivation. It's very hard to find. It's pretty much isolated to case reports. And so I think this is really interesting that we're seeing this. Since the first patient happened, we've now decided to check PCRs and surface antigens at loading dose and first maintenance dose for those that are core positive, regardless of surface antibody status. So maybe because we're checking, we're seeing it, but definitely something to pay attention to.
Go ahead, Darcy.
I was going to just ask, did you, after switching and then checking the hepatitis B PCR, did you check those people because of symptoms or because they had a transaminitis, or just because they had been isolated core antibody positive?
Yeah. Thanks, Darcy. It's a good question. So both patients had normal liver enzymes. I didn't include that here. So the first patient was kind of randomly checked. He was having some nondescript abdominal symptoms. It was related to other things, but it just happened to be checked, and that's why it was found. And since we saw that, that's when now for the second patient, we kind of instituted the regular monitoring. And that's why for the second patient, we were checking. So neither of them were symptomatic. Neither of them had LFT elevations.
The thing that Jill and I were kind of chatting about privately was just at baseline, does it make sense to check a hepatitis B PCR for people who are isolated core antibody, especially if they're on a tenofovir containing regimen, right? Because they're probably going to be suppressed, although, potentially not. And, I know the guidelines changed relatively recently for people who are isolated core antibody to give them a one-time dose of hepatitis B vaccination, see if they have a seroprotective response 1 month later. And that might be an alternative strategy instead of checking a PCR, is to just vaccinate these people, check them 1 month later, see if they seroconvert. If they do, you could probably feel, more comfortable switching them off of a tenofovir containing regimen.
Yeah, and that's a good point. And actually, Darcy, we're not doing PCRs at necessarily baseline for everybody, but if they've never had one before, and they're core positive, that's when we were doing it, because I think it is recommended to do a one-time Hep B PCR to rule out occult hepatitis B, although that is that is affected by being on tenofovir or not. But yeah, I think you make a good point.
Go ahead.
Go ahead.
Sorry.
No, I think there was a lot of controversy about giving the vaccination for people who are core antibody positive. But we know that a significant proportion of our patients with aging, they will lose actually the surface antibody. In our group, at least we've been doing this for a decade, and I will be very careful in monitoring those individuals, and I will give them the shot if they lose or they don't have surface antibody protection, because they are probably a higher risk of flare.
Yeah, and I think what's interesting though too is that, I think when you look in the literature, there's not necessarily great correlation between surface antibody levels and risk of reactivation, meaning those that reactivate, you still see reactivation even in those that have surface antibody levels, unless they're extremely high. I was talking to Jeff about this. I think there's a correlation if they're very high levels may confer some protection to reactivation, but yeah.
Yeah, I will be cautious if we are going to pull even 3TC out of the regimen.
Mm-hmm. I'm going to skip this last section on weight gain and just wrap up with some of the unknowns, which is we've got Q2 months coming very soon and how that's going to affect logistics. Use in those with unexplained persistent low-level viremia. We have that conversation a lot. There are still some certain NNRTI mutations that are a little bit questionable. For example, V106I. I queried ViiV and they had nobody in their studies that had that at baseline, but Stanford does predict it as potential resistance to rilpivirine. We're giving CAB with other long-acting therapies like Vivitrol, but that's not something that's been studied. CAB for PrEP and its implementation challenges. And then I just caution everyone about insurance changes in the new year as we roll into likely insurance changes and how that affects things. So I know we only have a couple minutes for questions, but thank you.
Fortunately, we got a lot of questions throughout. Nettie asked, for convenience of med access, could you use Juluca for lead-in or bridge when needed?
Yeah, I mean, you can. My only issue is patients who were not on Juluca before. Now, there's differences between taking Juluca orally versus injecting cabalpivirine, right? And it's related to rilpivirine. So my preference would actually be to go to their prior oral ART.
And this was such a thorough, yeah, I think that you just hopped through the weight slide, but I knew I think people were probably curious about that, and we do have a minute.
Yeah, I can mention about it. So we had one patient, she was a female patient who gained 15 pounds with a switch to cabalpivirine between April and September. And she had been on Complera before. She actually had wanted to be on a TDF-based regimen after gaining weight on multiple other regimens. We had talked about switching off cabalpivirine, and she had decided to stay on it because basically she said when she thought about taking a pill again, she didn't want to do it. This summarizes the weight gain data from the studies. There was similar amounts of weight gain in the FLAIR study because these were naive people, either started on Triamec and continued or switched to the injectable, and it was about 1.5 kilos at 48 weeks. In the switch study, they saw a gain of 1.8 kilos after 48 weeks in the cabalpivirine arm. They did not break this. I haven't yet to find a breakdown based on what regimen they were switched from, but there were definitely TDF containing regimens in the baseline group. So I suspect some of that has to do with the removal of TDF from the regimen.
And that begs the question, should you just sprinkle everyone with a little TDF? No, I'm just kidding. I think, are you going to write up your experience and publish this? I think that's a no-brainer.
It's been submitted to CROI, so hopefully it gets accepted. But yes, that's the plan, to dive a little deeper into our experience as well.
And Lucas, I think you may get some requests for some of I think you said the slides were shareable. That was a question to me. And then I think people would love to be able to access or at least look at some of your materials. So you may get some emails about that.
Of course, happy to do that.
This was really amazing. Finally, so great to see this in real real time, but real world, how this actually has worked. And we all know how much time and effort you and the group have put in. I don't want to, you know, Jeff and Carrie and Alan and everyone that are there. I hope I'm not missing anyone. I know there are a lot of other people who've been part of this, but it's just been incredible to watch y'all do this. And I'm curious about who the people are that have put on 50 to 100 people. I don't know if that was someone saying, you know, if that was Carrie responding or something. But it does seem like this is one of the largest, you know, operations that we have running in San Diego, but I don't know that for sure. So it's really great to hear from how this has gone for everyone.
All right. Thank you, everybody. I appreciate your time.
Thanks, everyone. We'll see you next week. Oh, Will did it. Will was answering for our clinic. Okay, well, good. Anyway, bye, everyone. See you soon.
Bye.
Thanks, Sarah.
Thanks,
Nice
Lucas.
talk, Lucas.
Thank you.